All right, and is everyone seeing the slides now?
Yes.
Okay, great. And I have started the recording, so I made sure to do that. So we'll give it one more minute and then we'll get started. And I have two colleagues with me today, Liz and Haley, and so they're going to be monitoring the chat. For some reason, when I'm in present mode, I'm not able to see the chat, so they will be monitoring that today for questions. All right, well, I have had the pleasure of talking with many of you over the course of the last few weeks about this project. We're so excited to be launching Store It Safe in Indiana. Today is our first learning session, and we have it's a three-part series. So we're going to be covering some background, screening, and workflows. And Dr. Matt Landman and Dr. Tina Zhang will be presenting today, and they'll talk a little bit more about themselves when they present. And as you know, I've talked with many of you. I'm Kristen Fluid. I'm the Senior Quality Manager here at the Ohio chapter, and we are collaborating with Indiana on this wonderful project. Did want to let you know that presenters do not have any financial relationships to disclose, and we want to give a big thanks to the Indiana Department of Health for funding the project. So these are the practices that are going to be participating in the project. If you should happen to not see your practice up there, please make sure you send me an email and let me know. What I'd like you to do so that we can keep track of attendance, and we'll keep putting reminders about this in the chat, is please put your name and your practice name in the chat. That way we can keep track of who is with us. So like I mentioned, today we're going to be talking a little bit about Store It Safe, an overview and some background, talking about some screening and resources, and then we're going to talk a bit more about the QI portions of the project, workflows, and a little bit of homework or to-dos. And so with that, I'll pass it over to Dr. Zhang and Dr. Landman. I believe Dr. Landman is going first.
I think I'm first. Well, good afternoon, everyone. Matt Landman. I'm a pediatric surgeon here at Riley and the trauma medical director. Have been here for a decade, and I would first like to say it's great to see a lot of familiar names and some new names on the list. It really is an honor to do this work with you all. Something that is near and dear to my heart, as well as Dr. Zhang. Obviously, I see the downstream effects of this on a regular basis here on the inpatient side of things. So, Tina, maybe if you wouldn't mind, just go ahead and introduce yourself now so we don't have to interrupt the flow of the presentation. May work better if you don't mind.
Absolutely. Again, thank you so much to everyone for being here this afternoon. I'm a pediatric gastroenterologist at Riley. Have been involved in secure storage, which is something I'm very passionate about since I started my training in Charleston, South Carolina, and have been working to just meet more in the community since moving here to Indiana about 3 years ago. So really excited for the collaboration with Indiana AAP, with the Indiana State Medical Association, with all of our community partners, and getting this this project going.
All right. Let's rock and roll. So I don't think anyone on this call needs to be reminded of why we're here today. You look at the news, unfortunately, on a regular basis, and you see these sorts of headlines, and the number of unintentional shootings, the number of intentional shootings, sadly, is on the rise, and in that group is certainly a subset of patients who are using firearms, lethal means for suicide. And really the idea behind this project, when it's in Store It Safe, and more specifically, what got Tina and myself interested in this is a similar rise in those same sort of firearm related injuries. Obviously, this is a huge topic, and our goal is to work with you all and try to take a sliver of this and try to move the needle a little bit. We realize that this is taking a bite out of a large piece of pie, but the hope is that we can move the needle and see some downstream effect, some primary prevention. And again, we really appreciate you all's willingness to be that front line as we try to make our patients safer. I always say my goal is to work myself out of a job, and in this arena, I'd be very happy to be jobless. So I appreciate your efforts. Next slide, please. I don't think anyone who's been around medicine for the last few years probably has missed this slide, but this is New England Journal 2020, where for the first time in our country, CDC data demonstrates that the leading cause of death for infants and for children up to age 19 years is firearm-related injuries. It overtook motor vehicle crashes in 2020, and that number has stayed elevated and continues to be an ongoing public health crisis. And there you guys also see the drug overdoses and poisonings, which are increasing at the same rate. So this is an ominous slide, and certainly one in which we feel something needs to be done. And I think this slide is a call to action for all of us in healthcare. Next slide, please. And more ominous stats. The U.S. is a overproducer, if you will, of these firearm-related injuries. More than 90% of children killed by guns happen in the U.S., and it is a stat that persists. And it's something we're hoping that we can again move the needle on a little bit. Next slide. When you look at the breakdown, this is from Pediatrics in 2017. You look at a breakdown over 12 years, 1,300 deaths in kids up to age 17, and the breakdown is as you see there. So still more violent interpersonal type deaths, but the unintentional and suicide is really accounting for almost half of those deaths, and really that's where we're hoping to make a significant attempt at decreasing that number. Next slide. And again, these unintentional kind of firearm found is probably the most disturbing type of injuries that we see with firearm-related deaths. And sadly, there is a disparity as this epidemic of firearm injuries occurs. There is a disproportionate number of Black African American kids who are affected by firearm violence. And so we're also mindful of this important fact. And again, working to see that our work with you all can hopefully make a dent in this sad disparity. Next slide. Dr. Zhang.
Right, so here's just another data taking a closer look, a deep dive into some of these numbers as we kind of transition that focus onto suicide. This is specifically for children aged 8 to 12, and just really here highlighting similar to that global trend of an increase in death from gun violence, but we're seeing this in younger populations, and this is especially important when we think about how we approach screening and using those tools that we'll be discussing. Next slide. So specifically in Indiana, suicide in youth, just some data on the left from Department of Health and high school aged surveys. So what we know about suicides is that firearms are not involved in the majority of attempts, but they are strongly represented in fatal or completed suicides because they are such a irreversible way of inflicting injury. And so the suicide report from the early 2010s to 15 showed that for Indiana, this was the #1 state in terms of teens considering suicide in that time, and #2 for attempting suicide. And then more recently, the Youth Risk Behavior Survey, again in high school age, reported nearly half feeling sad or hopeless almost every day up to 2 weeks in a row. Over a quarter seriously considering attempting suicide, 22% making a plan. And in this survey, over 10% attempting in the preceding 12 months. Next slide. When we look at the data, this is from the most recent fatal overdose and suicide report, with both of these numbers going up, as Matt had mentioned earlier. So in 2023, there was a decline in overdose from 2022. However, we saw an increase in suicide deaths by over 3%. And again, this pattern of this increasing over the past 5 years. When we look at age-adjusted rates of suicide in the state, this is above the national rate, and both of these are above our ultimate healthy people 2030 goal. This is, in addition to racial disparities, this is higher in rural counties compared to homicide related in urban, and just highlighting here the top counties in Indiana with the highest rates of suicide. And within that number, what we also see in comparison to 2022 is an increase in percentage of completed suicides by firearms. Next slide. So overall, just kind of stepping back again with the facts about suicide, we know that this is the second leading cause of death in people in this age range, 10 to 25-year-olds in the US, and our rates are rising. I'm sure as many of you see in taking care of your patients that there are increased visits for suicide attempts or mental health crises, that this trend is continuing. And so our efforts are to take a step in making an intervention that will be effective. Next slide. So breaking down, as we mentioned again, that of those patients who complete suicide, firearms are the majority. They are so effective. And of those, 82%, in a previous study showed that they obtained that firearm from their home, which gets to access and how can we prevent this from happening. Next slide. So this data came from a study looking at not completed, but suicide attempts and surveys showing that the time lapse between decision and the actual attempt is actually quite short. So of these surveyed, 50% highlighted here made that attempt within 20 minutes of making that decision. About a quarter actually within 5 minutes. And if I remember correctly, up to 70% within an hour. So this is something that can progress very quickly. And as we know with adolescents, the ability to make perhaps a rash decision is still very much part of who they are in their development. And so our goal is to implement that barrier with just eliminating that immediate access to lethal means. Next slide. And we have data to show that barriers to lethal means are effective at reducing suicides, much in the way that this works for other forms of injury prevention, such as a fence around a swimming pool, just as one example. Next slide. So in terms of how are we going about this, this came from the American Academy of Pediatrics a few years ago, this blueprint for youth suicide prevention, and just highlighting here the role for primary care physicians to be able to implement an effective intervention, that we are in the position to identify and provide resources for youth that are at risk. Highlighting just a few ways for us to do that effectively include universal screening, using standardized clinical pathways that of course need to be developed for your practice, your resources, clinical workflow, and that's what this program is about, as well as leveraging all of the care team members that we work with, knowing that that one person can't do it alone, that it takes the community, but that when we think about how to make the process work, we can really begin to make a difference. Next slide. And so from this report, just a few statistics, again, to highlight the important role of healthcare contacts. In this report, they highlight that of the adolescents who completed suicide, 80% had seen a healthcare provider within the year. About half of them an emergency department visit within the year before death, and over a third had a contact within the 4 weeks, and in our older adolescents, a little over a third actually within the week before their death. So these are, I would say, opportunities for us to take a look and see how in the healthcare system we can make a meaningful intervention. Next slide. It gives a little bit of background in Store It Safe, which Kristen is very well familiar with. Grew out of really, I think, unique collaboration in Ohio with AAP, as well as firearm safety experts, a firearm gun owners association, community organizations, all ultimately with the goal of keeping our children safe and decreasing these injuries and deaths. And so we can see the timeline here, and we're really excited in Indiana and this year to be able to expand that, to use those resources and build on the progress. Next slide. So taking a look a little bit more detail at the screening and resources that we have available and we're excited to distribute. Next slide. What we're focusing on in this first wave of quality improvement is specifically suicide screening, incorporating that into what is, I'm sure, already standard of care for depression screening. So what we know is that screening for depression alone is not enough, and using the PHQ-8 or a similar depression tool is going to miss patients who would screen positive for suicidality, for suicidal risk. And so PHQ-8 versus the PHQ-9, which does include that additional question, seen on the left, in conjunction with a suicide screening, such as the ASQ that's shown on the right, is our goal here, what we're wanting to add to the great work that's already being done. Next slide. And so the current age recommendations for suicide screening, as I'm sure you all know, is that universal screening for ages 12 and up, but then highlighting that that graph that was shown earlier for increasing suicide in youth ages 8 to 12, also screening when clinically indicated in some of those younger categories down to age 8, not necessarily indicated under age 8 unless there are specific warning signs present on your exam or history. Next slide. And so what that suicide screen is expected to look like is a very brief screen, less than 30 seconds. The ASQ is an example of 5 quick questions. And if that is screening positive, then to move forward with a safety assessment, and based on whether this is acute versus non-acute, how that is stratified, moving forward with those next steps in that clinical workflow that'll be developed. And then based on that, then deciding what type of follow-up is needed if they are in acute crisis versus needing a outpatient referral, close clinical follow-up, specific resources provided, kind of stratifying based on that. Next slide. This is one example of a safety plan, and this and other resources are going to be provided. But this is something that if it comes back positive on the screen, can then be that next step, working closely with the patient and the family to create an individualized safety plan, identifying contacts, resources, coping strategies, warning signs, as well as the behavioral health, mental health resources that might be needed. Next slide. So this is one example of a flowchart of how this workflow might happen. highlighting at the very beginning that this is a universal screening process. So anyone aged 12 to 21 who is getting a preventive health visit, either a well child check or a sports physical, not only getting that first screening for depression, but then a secondary screen for suicidality, and then including in that our counseling, discussing suicide risk, secure storage, providing resources, offering that lockbox to all families. Because what we know is even if kids are doing well, things can change or things can lie under the surface, and having that concept of a safety plan, of having resources should something change, of offering these resources, whether referral, lock boxes, can make that difference when if a crisis were to occur later on outside the office. And then below you can see walking through what happens if there is a positive screen, some stratifying based on the score for PHQ 8 or 9 in terms of depression, as well as separate workflow for suicidality, things like evaluating, creating a safety plan, developing follow-up, referral, versus, of course, if this is an acute crisis, things like one-on-one sitter and transitioning to emergency care. But lots of great resources here, QR codes to some of those that we've shown. Next slide. And then, of course, with screening, this is work that is being that's part of your clinical care. Encourage, of course, for this to be billed, and that might differ from office and practice to practice. But here you can see the code for emotional behavioral assessment with scoring and documentation. This can be done for each instrument, so depression, PHQ-9, as well as ASQ, with the modifier if there is more than one billing code. And that is about as much as I can speak onto that part. But this is something that I understand many practices are already doing. Next slide. And then links here to some of those resources that I mentioned, the first, that AAP blueprint for youth suicide prevention, as well as ASQ, the suicidality screening toolkit materials. Next slide. Here's a look at some more, more specifically at those resources that will be provided, both print and digital, I believe, will be coming out. And so left is the online toolkit, which is very comprehensive, a little bit more dense, but has a lot of detail for those who are interested and able to go down into each of those tabs on the right side of that screen. On the right side are the more focused, smaller rack cards that will include things in terms of being prepared for a potential crisis. So on the right, things related to restricting access to lethal means, how to craft a safety plan with your child when things are well, thinking about trusted healthcare or family or people that they can go to, and understanding when to move forward with that safety plan. And then on the left, tips and strategies for caregivers if that were to occur. Next slide. Here we have some more focused resources specifically for firearm owners. And this, I think, is really valuable, as I mentioned, developed from Ohio in their collaboration with Buckeye Firearms Association, firearm safety experts, really crafted with a lot of thought and care to do this in a non-confrontational, non-judgmental way with a focus on safety and injury prevention. Some data there on these in terms of just highlighting that education on firearm safety is not enough, that hiding a firearm is not the same as securing a firearm, and a little bit more information on ways to do that safely with some of the devices shown on the right, in addition, highlighting, including, of course, the lock boxes that'll be provided. Next slide. And then here's some more focused resources specifically for providers. the goal of this is to have everyone feel comfortable, confident, knowledgeable with doing the screening, with providing the counseling, knowing that this is the best way to ensure that children are not being missed who are at risk. So these are just some reminders, an example of the flow chart, and of course, I think the upcoming sessions will give us a lot more resources and chance to practice that. Next slide. Here are some RAC cards that are specific more to youth, and I think a great way to, again, approach this a little bit differently, targeted for youth that are potentially at risk of suicide, offering resources, really painting it as broadly that even if not for that child in that moment in your office, but perhaps they have a friend who shares something to them. What can I do? What action should I take? Giving them the confidence and empowering them to take that next step and resources. Next slide. And then even more things, printable versus digital posters and signage, just to make this a part of our standard preventive health care. Next slide. And I will transition over to Kristen.
Yes, thank you both. So we wanted to touch on kind of workflows because we do know that over the course of this project, you are going to be implementing some new things in practice. For any of you who've ever done quality improvement in the past, you probably have seen a key driver diagram. We do have one for the project. It's got a lot of dense information. It'll be shared with everyone. And we are always updating. This is an evolving document, so nothing on it is written in stone. But it is kind of our like guiding sort of document to help us with our goals and our interventions. So I just wanted to make sure you saw that, and I'll have that available for all of you to have. With Store It Safe, we do it many different ways with practices. We've had practices where it's a solo provider doing the project. We've had practices where one provider in a clinic with many providers does the project. And then we have practices who everyone involved or at the clinic is involved in the project in some way. So a team approach really is beneficial because there's different pieces and parts of the project that kind of if folks in the clinic work together. That's not saying that if you're a solo provider, you can't do the project, or, one provider in a clinic can't do it without everybody else. It definitely can happen, but many of the things that we talk about, it's good to start thinking about kind of who's going to do what and how it's going to work in the practice. The other thing I want to mention is that what I talk about today, and when we talk about workflows and these things over the course of the project, we often are giving you recommendations or suggestions, but we know that you know your practice much better than we do. You know what will work. You know how things will flow best. So these are always suggestions, and we're always here, to help with any challenges that you might encounter as you're implementing things. So I'm going to as we do the project, there's going to be obviously different kind of workflows. There's screening workflows, the lethal means restriction discussion, there's giving the resources, there's data entry for the quality improvement piece of things. So lots of different kind of moving parts and pieces that at some point we'll be kind of putting it all together. So today, since we're focusing on screening, a couple of the things to think about. All of the practices are already doing depression screening, but many of you will be adding an additional suicidality screening. So think about, again, what that process is going to be like for your practice. We do always suggest that when the youth are completing the screenings, that they're doing that privately so that, someone is not asking them those questions or so again, just trying to think about as you're implementing these things, when the best time is or how to do that. Also thinking about who's going to review the screenings and who's going to score them, how the provider is going to know the screening result, and then communication back to the patient and or the caregiver, the parent, about the results of the screening. And then obviously there's going to be documentation both in the chart and then with our Store It Safe quality improvement data entry. So again, what I'm going to show you now is a suggested screening workflow. It's not the only way to do it. It's one way that we've seen it done in practices in the past. So your front office staff might be involved in this piece of the project. They may give the depression and suicidality screening to the patient when they come to the waiting room. And then you may have clinical staff such as a MA or a nurse who collects the screening, scores the screening, documents the screening result in the chart and with the quality improvement data on the iPad. And then you may have the provider who would review the screening results, communicate those screening results if need be to the patient and family, and then develop a treatment plan and referral as needed. And then there would be some documentation as well for them, probably in the chart, and then also in the QI with the QI data on the iPad. So the other kind of piece of a what might be new kind of flow is the lethal means restriction discussion. That in our third learning session, we're going to have an entire hour devoted to just how to have those discussions and practice those discussions. So the one thing I want to continue to mention is that this is not a discussion that should be had based on the results of the screening. So it is across the board for your age 12 to 21 population for this project. So you should be having this discussion regardless of the screening results. I think sometimes because we do work on improving screening and we do this, sometimes that kind of can get connected, and it really is very separate. So this should be happening regardless of the screening results. The youth may or may not be present when you have this discussion with the parent and caregiver. And I say that because we have, over doing this project a few waves, heard that often parents may not disclose or talk about having a firearm if the youth is present. So you might, again, want to be thinking about that. What would work best, again, in your practice of when to have this discussion with parents at these appointments. Sometimes parents aren't even present at the appointment, so that's also a situation you might encounter. And then offering the lock boxes that you will have, again, thinking about, and I think as a project, we're going to also be thinking about when and how those are offered and to whom. And then the printed resources that you're going to get also would be offered regardless of the screening result. You'll have resources for the youth and resources for the parents, and then obviously documenting the discussion that you have. So again, a potential flow for the lethal means restriction discussion would be that the provider would have the discussion with the patient and caregiver, give the crisis rack card and the firearm owner resource to the parent caregiver, give the youth rack card to the patient, offer the safety lock box, and document again in the chart and with the QI data on the iPad. One thing I always want to kind of highlight is this is a previous run chart from a previous wave of Store It Safe. We see this consistently in every wave that we do when we ask caregivers at the end of the appointment, has anyone other than your physician today talked to you about the risk, talked to you about safe storage? Inevitably, we hear that roughly about 20% of the time, have families ever heard this information from anyone other than their child's provider? So I always highlight this to just say, we might think that people are getting this information in other settings at school or out in the community, but we hear time and time again that they're not. We also hear time and time again that they want to hear this type of safety information from their child's provider, and we hear good results when physicians do talk about it with families. So next time, which we're going to have our second learning session in 2 weeks, we're going to kind of put it all together. You're going to get your iPads, you're going to actually have them in your hand, and we're going to go through it and show you how to do it. It takes about a minute and a half maybe to enter data for an appointment. So we'll be able to kind of piece all of this together for you when we have that next session. So a few things that I wanted to mention for homework is, if you haven't already, and I know many of you have because we've been communicating about it, pull your team together and talk about the project if you haven't done that. Start thinking about your workflows. So now that we've talked about screening, now that we've talked a little bit about the lethal means discussion, think about how that's going to work in your clinic. I'll be sending out a follow-up email, so be on the lookout for that. It'll have today's slides, the recording, and then some to-dos as we're kind of moving toward that July 1st launch date. If you haven't already, complete the pre-work survey. Many of you have already done that. It's best to be done usually with a lead provider and a lead admin staff. And then please ask me questions. Again, as we are preparing to launch, there's going to be lots of questions that come up. I'm always available. You can email me, you can call me, you can text me, whatever works best for you. But please keep your questions coming. And then, like I mentioned, your iPads will be coming in the mail, and you will have them before our next learning session so that when we go through data, how we're doing that, and kind of get all that cleared up, you'll have those actually in your hands. Just a reminder, you should have a calendar invite for this next session, which is on Wednesday, June 18th from 12:15 to 1. But if you don't, let me know, but I'll be sure to send reminders about that. And again, we'll be recording that session. And so I think we still have a few minutes, so we can take questions if you want to unmute yourself, or Haley, Liz, if you've seen any questions in the chat.
Yeah, Kristen, there's a chat question about the tools that are available in different languages on the iPad. Can you kind of talk about that?
Okay, so on the iPad, and you'll see this when you get it, the only time probably that you're going to need anything in a different language is on the post-appointment family survey. So that's that survey that at the end of the appointment, you're able to give the iPad to the parent or caregiver if they're there. It's totally voluntary, totally anonymous. There's a little box at the top where they can select the language that they want the survey in. So for the other resources, you'll be getting printed versions in English for patients, and then we're going to be giving you all the translations that we have able to be printed and or be available digitally that you could put in an after visit summary or something along that line. So hopefully that answers that question. Any additional questions in the chat, Liz?
There's a follow-up question about which languages are available.
I can send you all of the languages that we have. So I know the ones that we had previously to this project we will have available. And then I know Burmese and Creole. What was it?
Haitian Creole is the other one we talked about.
Those are the two that we're having done for this project specifically.
I'd push it out to the group. Do you think I guess you'll see what the languages are, but those are the, in addition to Spanish and some of the other more common ones that we thought those were unique to Indiana. I'm not sure if there are any others that you can sort of Indiana specific groups that you can think of that we should make sure that we include in that list. Let us know.
Yes, and I can send out in the email a list of all the languages that we'll have. Great question. Any additional questions for us? If there aren't any more questions in the chat, oh, go ahead.
Yeah, Kristen, there's a question about emailing each group lead only, or do we all provide our individual contacts?
Yeah, so for most of you, I have the email addresses of all the providers that are participating. There's a couple of clinics that maybe gave me names, but not email addresses. I personally like to email everyone at the clinic. I feel like it's just a great way to make sure all the information gets circulated. So that's my preference, to send it to all the participating providers and the kind of lead admin person that you have identified. If you don't want that, if you only want it to be sent to the lead provider and like the lead admin, I'm happy to do that. Just let me know. I don't want to, be bothersome with emails to everybody, but I think sometimes when it puts the onus on someone to remember to send it to somebody else. So I just usually send it out to everybody. Great question also. If there are no other chat questions or anything you want to unmute for, I just want to give you one final reminder that if you are on the call, please make sure you have chatted in your name and the name of your practice so that we have that for attendance. And Dr. Landman, Dr. Zhang, any kind of closing comments?
I would just, again, thank Kristen for her incredible wealth of knowledge and I would say pragmatic understanding of how this is going to work. She is a problem solver, so she will be a great resource for all of you. And again, I would just reiterate that this project doesn't work without you guys, and it really is an honor to work on this, to try to facilitate it, and whatever we can do to try to make this easier for you, I'm all for it, as long as it's legal and I don't lose my job. And we really appreciate all the work you're doing. So thank you.
I second all of that. Could not say it any better. So we're so excited. So excited this is up and running.
Yes, and I have been so thoroughly impressed with all of your practices, your providers, your office managers, admin staff. You guys are so communicative. I just love you're so quick to get back to me about things. And so, again, to reiterate, we are here to help you. That is kind of my job to make sure you're successful with the project. And if there's things you need, if there's gaps in knowledge, if there's any of those things, when we hear from you about that, that's very helpful to us in improving projects and kind of what we do. So you always have my email address, you have my cell phone for texting. So please don't hesitate to reach out and we will keep moving things along. All right. Thanks so much, everybody. Have a
Thanks,
great
everyone.
rest of your Wednesday. Bye-bye.